no way comprehensive. This is just give you some basic stuff and important things that we focus on to orient to a little bit more, especially for people who have not been in ICUs before. Review. I'm Adele Bassily-Marcus. I'm one of the intensivists in surgical ICU, and we recognize we're dealing with a disease that, as you heard, the pandemic and it's expanding. I can tell you every day we're getting more patients die from the day before, as you from different sources and the media as well. This is a model that you see on the screen now, proposed by the Society of Critical Care Medicine less than a week ago. How are we going to stretch the capacity to accommodate a sicker patient, more patients, more volume with the current staffing? So obviously, strategic, and we welcome collaboration with other disciplines. I think the closest discipline to our intensive care practice is the anesthesiologist. So we appreciate this collaboration, and together the model here on the top is somebody who does critical care on daily basis. Below it, you have the non-ICU physicians. This could be the anesthesiologist, could be cardiologist, could be different disciplines. And then below that, there is a lot of other disciplines, including the CRNAs and other doctors and APPs, respiratory therapies. And then below them, nurses. Nurses that are familiar with the ICU nurses. Below that, nurses who are not familiar with the ICU environment. The model here, and this is proposed by the ICTM, and Rupa Kolisat is the director of the institute. She created this model and doing a lot of work to build our capacity to accommodate more patients. I just hung up the phone after talking about Sinai Queens. We're going to get a lot of patients from there. No question, there is volume coming to us every day. And this is our proposed model for Mount Sinai Hospital. Intensivists will be helping lead physicians. Again, these are the anesthesiologists. Below that, I want to emphasize the CRNA here. They are amazing talent and expertise in managing ventilators, managing patients, drugs, looking at the whole picture. We welcome their collaboration together. And actually, I'm expecting a few CRNAs to work with me in the ICU this week. And intubation, managing pressures, I think they are a great example of stretching our capacity to accommodate more patients with expertise, which we welcome. Again, they're going to be above them physicians, and below the APPs and the RTs and the residents, there is the ICU nurses who are on the front line and also carrying the fort for minute-to-minute operations. The typical model is mixing people together. So, for example, the APPs who are from the ICU with the advanced practice provider who are never been in the ICU together. Similar for residents, similar for the ICU nurses and non-ICU nurses. And I think this model will foster learning from each other. You're bringing a lot to the table, and we share our expertise as well. And this collaboration is the way to really pull through this. It's a difficult time. It's crisis. It's a pandemic, and it's a marathon. We haven't peaked yet. We don't know when this gonna get better, but we expect more and more operations. I just got a phone call from a friend of mine in Japan. They still haven't recovered from the Princess cruise ship that landed there. It was and they still haven't recovered from the crisis management. Again, this is a model. This way, one intensivist can oversee up to 80 patients. This is a model for Mount Sinai Hospital. No question that there will be need for education. Again, the Institute for Critical Care Medicine with the hospital created, this is going to come to you, educational tool, and there are links, the blue hyperlinks, you're going to get them in email. The first one, a lot of education material from the Society of Critical Care Medicine. Below it, a handbook for critical care management that's prepared here at Mount Sinai, and then other resources including videos, including short modules. Topic might not be familiar with the anesthesia staff. For example, withdrawal of care and breaking bad news and things that not very familiar with you. And some of the stuff will be familiar, airway management and ventilator management. I think these are close to home. There are special management for ARDS and COVID patients. I'm going to go over a critical point, but there will be more resources, which I think this is good. And we're really prepared well in terms of equipment, capacity, staff. We are really in good shape compared to other hospitals in the area in New York City. And thanks to our leadership, and we're able to. So this is the Society of Critical Care Medicine educational resource. This is critical care for the non-ICU physician. When you click on that, these are free, like short lecture with audio. You go through slides. I found it very if you have time to do that before you get to the ICU, that would be great. If not, as you go along, critical care for older adults, mechanical ventilation, management of shock, respiratory failure. Overall, I think it's useful. This is the outline of the talk. I'm going to talk briefly on the respiratory failures, special management for ARDS and mechanical ventilation, shock, inflammatory markers. What are you doing special for the COVID patients, and what do you do in general for patients who are in the ICU, and the role of palliative care. Respiratory failure, there are two forms, hypoxic and hypercapnic. The hypoxic PO2 is less than 60 in room air, and hypercapnic more than 50. And the most common form is mixed, especially in COVID ARDS. This is a picture of ARDS. It looks bilateral, infiltrate. You may see pulmonary vascular congestion, not as much as alveolar. Looks fluffy, and believe it or not, patients do get better. The mortality rate is still high, but the one who recover, they may have up to a year later a little scarring, like in this picture, and decreased pulmonary function, but they survive. ARDS is a syndrome. It's an acute respiratory distress syndrome. We'll go over the criteria to diagnose it. So on the left side of the screen this is a cartoon of the normal alveolus, and in relationship to the capillary, the pulmonary capillary. You see there is not much gap between the gas that's in the air in the alveolus and the blood and the RBCs in the blood vessel. You see type 2 pneumocytes produce surfactants, allow the gas, and you see healthy macrophages protects and cleans up any material. There is some fibroblasts. In ARDS, there is destruction of this milieu. It looks like really a hostile environment. You have the capillary leaks, you have the neutrophil migration, you have the result of the cytokine release. You have the hyaline membrane formation along the alveolus. You have the macrophages with all cytokine TNF alpha, IL-1, IL-6. You have cellular debris. You have activated neutrophils. You have inactivated surfactants. You have fluid-filled alveolus, and often they are even collapsed completely. So you can see the gas exchange here, which is a hallmark for ARDS, and it is the problem with the coronavirus in general, especially in COVID. So ARDS, again, stands for acute respiratory distress syndrome. There are 3 criteria. It has to be acute, meaning these changes on the X-ray that you saw, it should not be from months and chronic condition, pulmonary fibrosis, for example. It has to be within 1 week of onset. And then you have the chest imaging, as I showed you the picture before, bilateral opacities. You may get a little effusion, but it does not explain the degree of the hypoxia. And then you have, it looks like pulmonary edema. You have acute onset, you have alveolar edema or interstitial edema, and you have hypoxia. That could be easily pulmonary edema and heart failure. So you need to rule that out to really qualify it for ARDS. And the way to rule it out, clinical history, if somebody is already in advanced heart failure and now it's getting a little bit worse, it's different than somebody who's healthy with reason to suspect cardiogenic etiology of this pulmonary disorder. Or you can do echo. We don't put Swan-Ganz anymore. Used to criteria used to say you need to rule out pulmonary edema by putting a Swan, and you check the pulmonary arterial occlusion pressure less than 12 or less than 18 actually. This have to be invasive. A simple echo or history or exam will be enough. And then we'll break it down, and this is a classification between mild, moderate, and severe. It's all the difference, the ratio between the PaO2, this is the arterial oxygen content from the arterial blood gas, divided by the FiO2 in percent. For example, if you have the PaO2 is 50, and you're on 100% FiO2, that's 1, 50 divided by 1, that's 50. This category is severe, which is the PF ratio, the ratio that I just described, less than 100, that's severe. From 100 to 200, it's moderate. Between 200 and 300 is mild. And this is roughly the classification for ARDS. It's a little bit new compared to the old traditional classification, which did not include the acuity part. So that's a Berlin definition from 2012. So again, the virus gets in the oropharynx, people may feel sore throat, may develop fever, which is 85% of them develop fever and could be high, and then goes down into the respiratory tract and then causes damage in the alveoli. So the patient starts complaining of cough, fever, and then when they get into shortness of breath and you recognize that hypoxic, this is when you know that's really got into the alveolus, and now you're having filling the alveolar with the capillary leaks and the debris that we described. Always in the mind is this patient needs to be intubated or not. See if the patient is going to get better with supplemental oxygen. Try simple nasal cannula. You can consider high flow nasal cannula. Be aware that high flow nasal cannula, which could give you 80 liters per minute, it's really aerosolizing procedure. The virus can be aerosolized. So patients, when you try to use high flow nasal cannula, make sure you're in a negative pressure room and the staff is really equipped with appropriate PPE, including the N95 or PAPR, because the environment now is going to be aerosolizing environment. From experience dealing with these patients, don't prolong the high flow nasal cannula. These patients rapidly progress into fluid respiratory failure. And there is another limitation, which is how many high flow nasal cannula we can accommodate at a certain time. So there will be a supply issue down the road. So that also needs to be factored in. However, what we notice about these patients, when they get to that point, they decompensate quickly. So they need to be closely monitored, and any signs of decompensation, do not hesitate to intubate, do not delay intubation. As soon as the patient starts to get worse, despite what you're supporting the patient with, you need to really consider intubation and not delay. What about the role of non-invasive ventilation like BiPAP? Some people think that because the patient on tight mask is not aerosolizing. The reality is it's actually the patient doesn't keep the mask all the time, and that could be aerosolizing. So the same Same applies on the non-invasive, which is make sure it's negative pressure room and the staff is in appropriate gear, with including the N95. Do endotracheal intubation quickly, efficiently, rapid sequence. The most experienced person will rely on the anesthesiologist and the CRNAs who have a lot of experience with that to do that in conjunction with the intensivist. This is not the time to teach or learn, so it needs to be done quickly and often without bag ventilation, because you want to intubate quickly to control the respiratory circuits and connect the patient to the ventilator. Minimize the staff in the room, proper equipment, as we mentioned. We target the saturation, whether the patient on the vent or before the vent, not too high, 92 to 96, not more than that. This is general management of the patient with COVID-induced ARDS. Tide of volume between 4 and 8, typically 6 mLs per kg. So somebody 60 kilograms, you give them 360 mLs. Target plateau pressure, and you get the plateau pressure by holding inspiratory pause for a second, and then you see the plateau pressure on the ventilator. Investigate for bacterial infection. We're learning more and more there might be co-infection with bacteria, and there is a role of antibiotic prophylaxis here. Again, target the O2 sat, as we mentioned, 92 to 96. Conservative fluid strategy. Remember the image of the debris in the alveolus. Imagine on top of that you have fluid overload. You're just going to worsen the gas exchange. So try to conserve in the fluid. This is not your typical septic shock patient where you give 30 mLs per kg. For somebody with 70 kilograms, that's over 2 liters. Here, there is role of starting pressure sooner. You can give a try of fluid, but not to the point of fluid overload, and start pressures earlier. And we talked about the empiric antibiotics. What about moderate and severe? Higher PEEP. I'm going to give you a little table on the PEEP. Not unusual. We have to heavily sedate and even paralyze patients. Prone if they're still refractory after paralysis. If that still fails, we really need to think if this is patient whose prognosis still before this episode was had a good chance of survival or not, and then you can consider alternative or adjunctive therapy like VV ECMO. Unfortunately, with this virus, unlike the SARS and Middle East respiratory syndrome, both responded well to ECMO. The data we have so far, no way conclusive, but does not show that ECMO made a difference in the outcome. Steroids were learning. It used in the prior studies in ARDS never showed benefits in corticosteroids and to prevent long-term fibrosis. We are seeing more reports from China started showing that steroids in this setting helps with the cytokine release, and there might be a benefit. And anecdotally, we noticed here the oxygen requirement does not progress as fast as used to be when we start steroids. So we may even change our protocol to include steroids. Currently, it's not part of the protocol. Mechanical ventilation, use familiar mode. The typical mode is assist control. We'll talk about that. Start high on the PEEP and FI2, 6 mLs per kg. We talked about when you use the tide of volume between 6 and 8 or between 4 and 8, it is a low tide of volume. You can compensate that by increasing respiratory rates, and we should expect and allow some hypercapnia, accumulation of the CO2. We allow pH to go down to 7.20. Target is to keep it above that number, but it's okay. When it goes below that, then we need to do something else. Some people use bicarb, some people start increasing the volume. So the tidal volume limit different ways, but typically it's okay to allow some CO2 retention. The pH does not need to be normal. This is from ARDS net protocol. You have a lower PEEP and higher FiO2, and then a higher PEEP and lower FiO2. And I'd like to start when you're on 100%, somewhere between 18 and 24. The general advice here is go down on the FiO2 first, followed by going down on the PEEP. The purpose of the PEEP is to keep the alveoli open. In randomized control studies, there's no difference in outcome, but this is a multifactorial disease and a lot of things happening contributing to the mortality if you're looking at just the mortality. But there's definitely a role in PEEP in keeping the alveoli open and preventing the de-recruitment of the alveoli. And the purpose of the proning is to help recruiting of the old alveoli that are collapsed already by draining with gravity all the edema fluids and allow the air to expand again. This is the most common mode of ventilation. It's assist control or volume control. And patients who are sedated and paralyzed, every breath the machine is delivering the inspiration, and then over 1 second, and then about 2-3 seconds the exhalation or the expiration. When the patient is awake and trigger the vent, they're going to get the guaranteed tidal volume. There are newer modes of volume controls. One of them is called volume control plus or pressure regulated volume control. It allows distributing the tidal volume within the inspiratory time through automating with the computer managed flow rate. So the flow gets adjusted automatically based on the rapid rise of the airway pressure during the delivery of the breath. So it can be stretched throughout the whole 1 second of inspiration, or you can change the inspiratory time and make it 1.5, for example. Then you're doubling your inspiratory time, pulmonary pressure. Other modes of pressure control, well, you set the pressure, upper limit of pressure will be 30. The lungs are stiff, and patients usually reach very quickly. They end up getting very small tidal volume. They don't like it. They don't tolerate it. You have to paralyze them. It has been falling of use because the other newer modalities like the pressure regulated volume control allowed us to utilize more the inspiratory time more efficiently, so decreasing the intrapulmonary pressure. Regardless of the mode, whether it's a straight volume control or you always want to keep the plateau pressure less than 30. This is the typical initial ventilator settings, 6 mL per kg, 100%. PEEP, you can start 18. Some people worry when they PEEP, we're going to have effect on the hemodynamics and creating hemodynamic instability because of the venous return. In fact, when you increase it, some people start 10 and then go to 18 and then 4. You can start either way, but recognize that on 100% you need to be on a high PEEP. Oftentimes I see 100% of people 5 or 10, which is very low. You need to be a much higher PEEP. And you can increase the respiratory rate to allow more of compensation of the CO2 retention, with the caveat that the CO2 retention is okay to occur in this element because you're trying really to prevent the barotrauma. Again, it's a heterogeneous disease. Some of alveoli are open, some alveoli are completely collapsed, but other alveoli are overdistended. So by giving larger tidal volume, you end up giving most of this tidal volume to the already stretched alveoli, and they can pop, causing spontaneous pneumothorax and the barotrauma that we try to prevent by giving low tidal volume and maintain the PEEP. This is one of ventilators. We're getting different ventilators now. This is the Puritan Bennett ventilator. Just a quick look at it. The bottom part is what you set on the ventilator. So you set the tidal volume, respiratory rate, and the FiO2 and the PEEP. And then the top part is what the patient is doing, how the patient is doing on this mode that you put the patient in. So you see the respiratory rate, you see the volume, multiply the two, you get the minute ventilation here. You see your PEEP and the airway pressure, the peak and the mean. And then in between this bottom and top, you get the waveform, and you see what's happening in terms of the pressure. This is where you detect the auto PEEP, meaning there is not enough time to exhale, and the breath gets stacked and accumulating, and the patient can get trouble because of the intrathecal hypertension and again barotrauma with hemodynamic instability. So always try to look for auto PEEP. You check the plateau pressure by pushing inspiratory pause. The machine automatically just hold it for 1 second and then give you a number, usually somewhere here in this corner of the graph. It tells you what the plateau pressure is. Target is less than 30. 30 is okay as well. When you do expiratory pause, this is how you detect the auto PEEP. Although you could see, you see it on the waveform, that the expiratory limb of the flow, it doesn't go all the way to baseline, and then the next breath goes in, so you know there is an element of auto PEEP here. The easiest way to fix the auto PEEP is decrease the respiratory rate. Yes, you can decrease also the volume as well, but more efficiently decrease the respiratory rate. So these are recommendations published about a week ago from both societies, Society of Critical Care Medicine in the United States and European Society of Internal Care Medicine, and basically collecting the evidence that we already know about managing patients with ARDS and making updates and recommendations based on what we know so far regarding COVID from the Chinese experience. So obviously you need to give supplemental oxygen. Here we suggest using high flow nasal cannula with the caveat I mentioned about the aerosolization. You can use that over conventional oxygen. Non-invasive ventilation, high flow is still better than non-invasive ventilation. There is no recommendation to make using the helmet non-invasive positive pressure ventilation. Success there is not as expected, so there is no recommendation regarding that. Regarding non-invasive ventilation in general, they could not come up with suggestion. Know that patients who are not used to this type of mask with pressure, with air blowing in their face, and they're already in their respiratory distress, adding that layer, they not all do well. Unlike the COPDers who are familiar with that, they can tolerate it, or the patients who have obstructive sleep apnea or familiar with it, they probably tolerate it better than people who are novice to this modality. The experience with that is still small. And patient, when they get to this point, you need to really highly monitor, probably in ICU, not on regular floor, and low threshold to intubation if the patient did not show signs of improvement or even decompensation. A few other recommendations regarding mechanical ventilation: use conservative fluid strategy. We mentioned how when you have pulmonary edema on top of the gas exchange problem, it's going to get worse. So we try to keep negative fluid balance as much as possible, not to overload the lungs that's already inflamed and leaky capillaries. Proning would be the next step if you have patients after you paralyze the patients. Typical proning between 12 and 16 hours. Some people extend it to 18 hours. There's no benefit beyond that. Not all patients can tolerate proning. The recommendation for proning is not to delay it to the point patient at the extremis. So we typically want to consider proning when the PF ratio mentioned is less than 150. So like halfway between, not to wait to get to severe and then start thinking about it. You need to initiate sooner the proning to get the benefit of the gravity pulling the fluid away. ECMO, the experience is not great so far. We don't have enough data to make a recommendation here. It's in the algorithm of management of patients after proning. Prognosis, obviously, when you get to this point, it becomes worse. So you need at this point to address if this is best interest for the patient or not, and bring goals of care discussion in the picture. Before we move on to circulation and shock, I'm going to stop to answer any questions regarding ventilation.
So one of the questions was on whether or not you feel like putting patients on high flow nasal cannula or BiPAP have actually avoided intubations, or have they all ended up being intubated anyway?
Not all. I have here Evan Liebner, who's been on the floors running today, and he has his experience as well.
So this is Dr. Liebner, one of the RRT and ICU attendings as well. We're putting a lot of patients on it on the floors. Some patients, it's stabilizing them. Some patients, it's delaying the intubation. But with the sheer volume of patients and how hypoxic they are, we couldn't possibly intubate everyone who's desatting on non-air breather just from sheer volume. So we're trying it, and it seems to be going okay so far on the floors. But I think it will be seen how many of them are able to stave off intubation versus delay intubation.
Somebody is asking, based on the use of nitric oxide, are you finding that these patients are having right ventricular issues?
So recommendation of nitric oxide in general, I think that was one of the recommendations there, is not great. Don't delay it. Don't wait too long. First, it's inhaled nitric oxide could be aerosolizing. However, I don't know if I have the slide here. It's overall discouraged. There is no much benefit, but yes, there is side effects to the use of nitric oxide, including hemodynamic instability the patient goes through. We would only consider nitric oxide when the patient is already intubated and on the mechanical ventilation. And at this point, if they're still hypoxic, the next step, instead of going to nitric oxide, is a proning. We haven't seen good response from nitric oxide, at least from reporting from other sites, but things may change. So far, we don't have a good data.
I have a question. In the unintubated patient who is showing hypoxemia or low saturation, do we follow the number of the saturation, or also consider whether they are uncomfortable or not?
So it's kind of, at least on the floors, it's kind of a little bit of all the above. We're looking at the stats. People who a month ago would have been intubated now are staying on the floors, which is a learning curve for us all. But if people have been maintaining stats around 90, if they're not tachypnic and they're not working hard to breathe, we've been leaving them. If they start getting a little bit more tachypnic or a little bit more hypoxic, we'll trial high flow or BiPAP. Or if they look really tachypnic and really having hard work of breathing.
And for those patients, is there any value to self-proning or?
It's interesting concept. If patient well enough to do that self-proning, it's a little claustrophobic for them. Usually, when they need it, when they really get in trouble, they're already sedated and intubated, and they're paralyzed. When they're early on, not intubated, and they can prone themselves, that's an interesting concept. I don't think we studied it enough. We might learn from that too.
In my limited time in the ICU, the awake patient would come up 5 points in saturation, 4 or 5 points in saturation, if they could change position and go into self-pronation.
Thank you for sharing the experience. It's interesting, and again, we learn this disease definitely attacks more capillary leak that we see. So maybe we'll, if they're well enough, start it sooner. Hopefully, this can change into their trajectory from getting to high flow to the intubation. It's interesting if we can do that. One thing that we don't want to delay, again, the intubation. back to the previous question, the saturation, for some reason, younger patients tolerate hypoxemia better, but to a certain limit. We don't want to wait too long. At the same time, we also need to factor in what the patient's history and chronic lung condition. Not unusual to find somebody setting 85 and completely asymptomatic. So it's not just looking at the SAT, you need to look at the whole picture, including what the patient is doing. Not unusual, active smoker, they get used to this chronic hypoxic state. Whether good or bad, obviously is a different question, but they tolerate it well. Any other questions? Okay, we'll move along then. Thank you. Moving to shock. Shock in general, it represents about 1/3 of our ICU admissions. It carries high mortality rate to 60%. Most common form of shock is septic, and this is a nice cartoon to just give you the volume in any hospitalized environment, the volume of shock. So 2/3 of it is septic shock. You see the cardiogenic and hypovolemic shock is much smaller. It's combined less than half. The obstructive, like massive PE and constrictive pericarditis and tamponade, 2%. Distributive non-septic, like for the anaphylactic or spinal neurogenic type of shock, spinal cord injury, it's also as rare as obstructive. So by far, the septic shock is really the most common. And they, regardless of the etiology, they share similar presentation. Hypoperfusion of the brain leads to altered mental status and delirium, skin mottling, oliguria, tachycardia, and eventually hypotension. And you check their lactate level, and regardless of the etiology, the lactate is high. Echo help us a lot in differentiating or trying to differentiate between the types of shock. Distributive, we get redistribution of the blood volume in the vessels from vasodilation, but the heart, you see it very hypercontractile. With sepsis, we'll go into the echo of sepsis in a second. In cardiogenic, you get hypocontractility. In obstructive, you see that there is dilation of the right ventricle, for example, with the right atrium, as well with empty left ventricle in obstructive shock. They're very, to simplify the shock into 4 types. The hypovolemic shock, when you have less venous return from bleeding, for example, or severe dehydration. Pump failure, whether due to arrhythmia or the contractility, including heart block and VTAC and myopathy and MI. And then the obstruction, which is less common, fortunately. And then the sepsis, which is loss of vascular tone that leads to the redistribution of the blood volume and plummeting of the blood pressure. Interestingly, in sepsis, in septic shock, the cardiac output could be high, which is common, but could be initially low. And you look at the patient's echo, they're really hypocontractile. If you take these patients to the cath lab, you don't find any coronary disease, and it's all myocardial depression from circulating cytokines. And our site and my colleagues have published 20 years ago how this often reversible, and it has a good prognostic element when it's reversed, usually within 24 hours. Again, this is purely for septic patients. The lactate clearance. Lactate clearance is a marker of resuscitation, but also it's a marker of a predictor of survival. If lactate is clear more than 10% within the first 6 hours, the mortality decreased by about 10 to 11%. And within 8 hours, if it clears 20%, the mortality rate decreases by 22%. This is not unique to COVID population. This is from septic shock population, all what we know from literature. And normalization of lactate within 6 hours is a good predictor of survival. And the flip side of that is lack of lactate clearance in 12 hours increases the odds ratio for death by 2-fold. To summarize that, slower clearance, worse outcome. If you have persistent hyperlactatemia, you know that this is not a good scenario and patient is not going to do well. You need to really reevaluate the situation and discuss with the family about overall picture. Just keep that in mind. Conservative fluid strategy, not to flood the lungs. When you use fluids, use crystalloid, don't start with colloid. Pressures. First drug of choice by far for septic patients is norepinephrine. And if it's not available, then use vasopressin or epinephrine. Fortunately, we have norepinephrine available everywhere. It is our favorite drug, and the second agent typically is vasopressin. We learned last year there was a nice article show in cardiogenic shock looking at looking at epinephrine versus norepinephrine. We typically think of epinephrine, it has more positive ionotropy, so we would use it if we see there is septic shock with hypocontractility. But in looking at cardiogenic shock study, the outcome is worse. It could be related to the workload on the myocardium with epinephrine that's more than the norepinephrine. So again, another confirmation that norepinephrine is the first pressor of choice. We use it now through even a peripheral IV. We don't have to have a central line, although with COVID population, we don't have the time to spend to try to put a peripheral IV, and oftentimes it can take 30 minutes or even more. And sometimes it gets extravasates and becomes more of a crisis situation. So for this population, we use definitely more central lines. But before the COVID crisis, we were using norepinephrine through a peripheral IV, which was a new practice for us compared to years ago. Steroids, we use low-dose steroids for patients who are in refractory shock. So what refractory shock means? You give the patient septic shock, you give them enough fluids, and you're giving them pressors, and despite the pressure, you're going up still, or you're adding a second agent. That meets the criteria for refractory shock. So why we're giving it? There is concept of relative adrenal insufficiency. We consider shock is a major stress to the body. Some patients are functioning without stress at okay level, but they do not have reserve in their adrenal function. So when they are stressed, like in septic shock, they don't have the cortisol level to mount and overcome the steroids. If you can identify this group of patients and you give them the hydrocortisone, again, low dose, 200 to 300 a day, studies has been shown that you'll be able to reverse the shock sooner. It did not change the outcome in terms of mortality, but you get them off pressure sooner. But again, you need to meet this criteria of refractory shock to give it. There's no more value of testing the ACTH stimulation test because we're checking total cortisol, while the free cortisol could be not correlating at all to the level that you're getting. No question there is cytokine release, there is inflammatory response, IL-6 is high, D-dimer is high, ferritin is high, and LDH, also C-reactive protein, and troponins. So this is an interesting study published just a couple of weeks ago online, looking at patients who survived and who did not survive. Interesting, 33% of patients have combined cardiogenic with cardiogenic shock as well as respiratory failure. So there is a myocardium involvement in the disease, while only 53% purely a respiratory component. And how we check for that, in addition to echo, by looking at troponin levels. What's striking in this study, and this is not the first one to brings their attention to the troponin levels, the mortality, the patients who died had higher troponin compared to patients who survived. So that raises the question, is there a viral myocarditis that really gets a patient into higher mortality category if they develop it? It looks so far that is a possibility, needs more studies. Looking at other inflammatory markers, no question that the patient who died had higher inflammatory markers, but it is more striking with the, especially the troponin. Here, you see the patient without cardiac injury, meaning normal troponin levels, had much better survival. Again, these are small reports, difference between two categories, non-randomized, but it's an eye-opening, and maybe we should track our troponin levels more often to see who's getting into higher level instead of just one or two levels. So that's also a consideration. Appropriate PPE, no question, we all need to learn that. We hear a lot about colleagues and healthcare workers getting COVID virus infection. We don't know if they acquired it from the community, which is very possible, or acquired it by caring for patients who are have COVID positivity. Unfortunately, the front line of that category is in the ED. A lot of the earlier report ED healthcare workers acquired the COVID. I think now we're paying more attention and we don't take anything for granted. So appropriate PPE in case you're dealing with patients with aerosolizing procedure, whether it's an intubation, tracheostomy, taking patient to the OR. I believe that became part of our protocol to know their COVID status. But I think in this day and age, we found patients who've been in the hospital for weeks and they have now COVID positive. So we need to be more vigilant in protecting ourselves. This study was published this morning. It was interesting, looking at hydroxychloroquine with azithromycin. And this is a French study, open label, non-randomized. Looking at the top graph, you see that the group who got hydroxychloroquine had much better outcome. These are 16 to 20 patients arms, so 3 arms. One is control, no hydroxychloroquine or azithromycin, the second one with hydroxychloroquine alone, and the third, the hydroxychloroquine and the azithromycin. And not only they benefited in terms of mortality because you give them hydroxychloroquine, but it looks like it's impressively better using azithromycin, which I think will be changing our protocol. Right now, it's not part of our protocol, but based on this data alone, the risk is low, but the benefit, it looks like there is mortality benefit, would be inclined to do that. Just be aware that both drugs can prolong QT interval, so we need to be monitoring them with EKG. Using systemic steroids, I mentioned earlier that there is no role of steroids in preventing fibrosis and ARDS on the long term. However, we see data coming from China, how steroids made a difference in the cytokine storm and preventing patients from deteriorating into higher level of oxygen requirement. So that's now changing, and anecdotally we see that also. There is insufficient evidence to recommend the use of tocilizumab. So tocilizumab is an IL-6 receptor inhibitor. It prevents the release of the cytokine from the cells. We use it a lot for CAR T patients when they have cytokine release syndrome, CRS. And we have a lot of experience using it in this population of multiple myeloma that they get CAR T therapy. And it usually works very quickly. So there are proponents in using them. The society here, there's not enough evidence and there's no recommendation. It's actually in our protocol, especially in severe disease. So that's one of the therapies that we use. You probably heard by now, over the weekend, we started giving plasma with the antibody that's rich in antibodies from convalescent patients who recovered from COVID-19 infection. And this is a study just got started. We have a lot of hopes and promise that will help. I can stop now for more questions before I have a few more slides to go, and then we'll decide after that if we're going to do Epic or not.
I think they had questions about, I was getting text about workflow and Epic.
Okay.
If
we can talk about that. Any other questions? Then you.
Nope, I think let's proceed with the workflow and Epic charting stuff.
Okay, sounds good. So for patients in the ICU in general, we use the ABCDEF bundle, which is Surviving Sepsis Campaign guidelines and recommendation. A stands for assess and prevent and manage pain. B means do both spontaneous awakening trial and spontaneous breathing trial. So on daily basis, so long there is no contraindication, and in this case, high FiO2 requirement is a contraindication. If somebody on 100% FiO2 and high PEEP, you don't want to sedate, you don't want to wake them up. You want to keep them sedated till you improve their oxygenation and sometimes paralyze them. So you do daily awakening trial for FiO2 less than 50 or 50 and less, and PEEP less than 10, and you can entertain waking them up and assess spontaneous breathing trial using pressure support mode. So that to be choice of sedation and analgesia. We'll spend a minute on it. Delirium assessment and prevention, as much as possible. Unfortunately, patients are delirious because they're already septic, and on top of that, they have a lot of drugs. So delirium is very high in this population. There are ways of minimizing that. One of them, interrupting the sedation, not to over-sedate them if you can. Early mobility, if it's possible. Obviously with the environment, probably going to be limited within the room. And family engagement and empowerment, which is very critical. So what about the sedation? Obviously, the patient needs to be sedated and often heavily sedated, especially when the FiO2 requirement is high in the category of moderate to severe. So if the PEEP is more than 8 and the FiO2 is more than 50, that will be targeting RAS, which our sedation scale -4 and -5, meaning completely sedated and not moving. As they get better, then you can lighten the sedation or even interrupt the sedation completely and do awakening trial to perform spontaneous breathing trial. Propofol. Propofol is a good sedative, and you guys have a lot more experience using it. In our population, obviously, it can worsen the blood pressure and the shock state. It also has other side effects. It's not the drug of choice for sedation of these patients. We know they're going to be on the vent for a while, long time. We know they're going to need something that doesn't worsen the blood pressure. So despite benzo's reputation of inducing delirium, it is still our drug of choice for the one who need heavy sedation for a long period of time, and also who, especially in patients who are going to need paralytics. So it is our drug of choice. And don't forget the opiates, including the fentanyl and dilaudid. When the patient's getting awakened and get into agitation and uncontrollable, and you want to assess them for weaning, this is when we transition to dexmedetomidine or Precedex. We also have protocol for that. We usually combine it with Seroquel twice a day, and as needed as well, try to control the agitation after long intubation periods. Aside from vent, pressure, and sedation, what else? Good critical care is attention to different areas, and prevention of harm is key. So DVT prophylaxis, there's more and more reports, including last night or yesterday, there was a patient who was COVID positive and developed massive PE. So there is more reports of DVTs. It is not clear whether these DVTs because something special about them, or because they are immobilized and sedated and paralyzed, like most of our intubated patients who are in ARDS. So we're going to learn about this observation. We're watching that, but they do need GI and DVT prophylaxis we de-escalate antibiotics once the period of bacterial infection is over, or became more of this viral phenomena. Pay attention to nutrition and glycemic control, bowel regimen, make sure the patient has bowel function. We don't sometimes recognize patients being constipated. I'll show you in a few things. Prevent hypernatremia, and again, try to achieve negative fluid balance, especially when you see on the X-ray there is more of pulmonary edema picture combined with the alveolar infiltrate. This is just a quick presentation on round, talking about overnight events of the vitals, especially looking at the maximum and minimum, and what's the blood pressure and what pressures, what are the current drips, antibiotics, and what are we doing for COVID. And this is just a nice phrase to use as an example. And then after you're around, you want to make sure that you address what the needs, what the goals of the day. I'll show you the daily goal sheet, how we break that together. And the goal is to try to see if we can get the patient off this bad situation, poor oxygenation, pressures, and intubation. And don't forget to update the families. So what about palliative care? Palliative care has an important role. In general, palliative care comes in when the curative and restorative care has been up and down and start towards the end, not in the right direction. However, there is a role of palliative care, especially in COVID population. Imagine patients' comorbidities already up and down. On top of that, you have this horrible viral illness. When they get to a point of requiring proning, you know that factoring in the comorbidities, they're not going to do well. And this is when we bring early on palliative care to the point that we need to also recognize that before we intubate patients, often that's overlooked. Okay, patient in respiratory distress, we get called, we just intubate, not recognizing the patient with metastatic disease, has been in the hospital for long, and now we have this infection, or maybe has other components like renal failure and other comorbidities that hospital acquired as well. So we spend a lot of time talking to families about not doing things that we know is not going to lead to good outcome and beneficial to the patients. Final thoughts on management. We work together, and we have collaboration in this crisis, which is wonderful. And I think it's an experience that we're all learning each day. And this is hopefully once in a lifetime. I've never experienced a pandemic like this before. Even when we were worried about Ebola, we haven't seen a single Ebola patient in our institution. So this is very different. We're stretching ourselves, patient not doing well. Last night was worse than the night before. Every day we have more volume and more deaths. And it's going to continue like that. And the key to help our patient is to work well together, which I appreciate all the help you are offering. Again, the anesthesia team, including the CRNAs and the house staff, the residents, and the attendings. They're all wonderful to work with, always want to help. I want the CRNAs, not a lot of people know how skilled they are, so please let them know that you can intubate, you can manage pressures, you can manage all the patient the way you're doing well in the OR. You are great resources, and I want to make sure that people know that as well, and you are very appreciated. Be a leader, you are a leader, and we're all together. We can guide each other. Sometimes we pay too much attention to the small details, losing focus on the big picture. So every now and then we need somebody from outside. Hey, let's overlook the big picture. Let's see what's happening here for this patient or for this ICU that you are working, and we are in it together. Stay safe. We work as a team, and we'll pull through this. I have no doubt about it. And we have a lot of resources and support. You hear about the tent set up in Central Park. Again, this is thinking ahead. We did not run out of space yet, but we have a plan. We have a plan to double up the patient in the ICUs, which started already. We have plans on managing patients with anesthesia machine, already started. We have plans on managing 2 patients on one machine, already tested, and we're gonna expand more. So there is no question we're facing something we haven't done before, but we're adapting and we're trying new things. We're trying to see what best we can do.
Thank you so much, Dr. Marcus. Would you be willing, because a lot of people have questions about the prophylaxis order sets and things like that, could you take us through that sort of stuff with EPIC, as well as like the notes that have to be written?
Yeah, so there is a COVID order set. It's in the ICU daily orders and ICU admission order set, and it's independent order. If you just type in COVID, you're gonna find the labs that you need. You're gonna find the trending labs, some of the inflammatory markers. You will find the tocilizumab indication. The hydroxychloroquine is already there. The one thing that's missing now is the steroids we need to add, as well as azithromycin we need to add, because that's not part of the protocol. Things are changing rapidly. As of last week, we're saying no steroids, exactly less than a week ago. And now we're saying maybe we should give them steroids. And now more evidence azithromycin works, so another reason to start it, and the harm is less. So there will be changes in the order set. But look up COVID. I'll go over EPIC a few things with you over the next 15 minutes if we have time. Then, is it okay now?
Yep, let's do it. Show us how the workflows go and the sheets and all that stuff.
Sure. So first, to get the tools that you need to function the way we are in the ICU, you need to change your job here. When you get in the screen and you log in after you put your username and password, you need to change your job into pain attending. Don't ask why, but that's the workflow. And then the next step is your department. Make sure it's MSH anesthesia department. This is to get the tools, because if you don't do that, you're not going to see the reports that I'm going to show you. One thing I want to set you up is to create a new list on your own. Don't go to the system list, you'll get lost. So on the top list here, on the patient list, click on edit the list and create my list. And then after that, you can name it the way you like, my ICU, my whatever you name. And I want you to copy, click on copy. Basically, you're creating your headers of your list. It's like Excel spreadsheet, but you're populating what headers you want. So copy this list that I have and I use, and just look for SICU. There is more than one. This is the first one, and this is the number 15405. This is mine. You're welcome to use it. I think gets you started well, but you can remove stuff that you don't need. You can add stuff that you find needed. So there is a certain number of columns that you can squeeze in. I think it's 26. But if you pull my columns here, this is how it looks like. You have patient room number, name. This is for billing. I use MRN, age, length of stay, meaning hospital length of stay, ICU length of stay, non-surgical airway days. Let me see if I have data, meaning how many days the patient on the ventilator. You can see them here. How many days the vent is. We use the vent as a separate device, so patient has 2 devices. One is the ET tube and another one is the vent. It's always good to correlate the two. Surgical airways, none of them is straight. How many line? Is there any central line, including dialysis catheter? Foley's, who is the primary attending? My last notes. Some stuff you can remove, like you already know the isolation status. You see here extubation protocol, that's automatic, meaning do SAT, awakening trial and breathing trial. If the patient meets certain criteria, so the nurse does it. SOFA score, I'm going to talk about it not now, in a couple of minutes. This is when you open the patient chart. I like to use the comprehensive flow sheet. It gives you a lot of information. You have the vitals, you have the arterial line. You see both of them, the non-invasive and the invasive blood pressure. You see the pain scale. It's called CPOT, Critical Care Pain Observation Tool. You have the RAS score. Here you can see the patient with sedated, 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 and now patient is paralyzed. And you see here all the drips on the patient. You see the patient on cisatracurium, fentanyl, ketamine, midazolam. So they're using a lot of drips, and you see them, and you see the titration if needed. You see the dose change as well. One thing I want you to do is, you see where is this little arrow, the blue with the arrow on the right corner of the screen, in the middle of the screen on the right. When you click on it, you open up a sidebar. I would like you guys to use something called Daily Goal Sheet sidebar. Go to the wrench and then look up, just type in DGS, and this is the name of it. MSIP DGS sidebar, or just put DGS Daily Goal Sheet and make it your default. By doing that, you get this sidebar that's on the right side here. I'm just zooming in to see a lot of information. You see the ICU length of stay, hospital length of stay, when the patient came in. You see all the drains and the airways on the patient, including the peripheral IVs. Weaning, we're gonna go over that. Mobility, mobility graph, DVT prophylaxis, the GI prophylaxis, the antibiotics. Any antibiotics the patient is getting, you'll find it. The diet order, and bowel function. When is the last bowel function? This patient has been there for a short time, so there is no bowel function yet. When you click on the lines, and the word lines and drains from the sidebar, it takes you to the avatar. It gives you more visual what the patient has, and that's not unusual to have an ET tube and ventilator. This is actually what we want you to do. Usually nurses does it. Add an LDA, lines drain and airway. So you see the patient has 2 peripheral IVs, intubated, under mechanical ventilation, has a Foley. When you go in the weaning section, this part on the right, it says SBT, or spontaneous breathing trial and weaning. When you click on weaning details, it's going to take you here all the documented weaning in text, which is not very useful. But below it, you'll see the extubation protocol. If the patient is on trach, you see tracheostomy weaning protocol. This is followed by the nursing staff, but basically do the spontaneous breathing trial by applying pressure support 5 to 10 for 30 minutes to 1, 20 minutes, 2 hours. If fast, assess for extubation. If it's difficult airway, let the doctor know, and then proceed with the extubation with the proper preparation. There are red flags when you should not do the SAT. Patient going for palliative care, for example, patient on paralytics, deep sedation because of status epilepticus, asthmaticus. The spontaneous breathing trial, similarly, the FiO2 requirement is high, so it is okay if it's less than 50 and 50% and PEEP of 8. Above that, you shouldn't do it. So there is some guides to follow, and what are the signs of failure? Patient is tachypnic, not doing well, or desatting, or develop arrhythmia, or chest pain, or blood pressure is high, or abrupt changes of metastatus. Then we consider that failure of weaning, and then resume the previous mode of ventilation. More details when you click on the protocol after weaning. You see what step are you in the weaning process. Here you can see you are at the step of awakening. You haven't gone beyond that. This is different patients. Where you are is where the dark blue is. Spontaneous breathing trial, obviously patient did not get extubated, failed, and did not tolerate it, went back to the weaning mode. This is all coming from indirect nursing documentation. At the bottom of the sidebar, the Daily Goal Sheet sidebar, there's a SOFA score. You can see it here in 5. Now, you guys are the first one to see this. This is went live recently because there is value now in SOFA score in assessing patient's progress. So here you can see the last 72 hours SOFA score in a graph mode. When you click on it, it's actually from overview report. When you click on overview report and you scroll, you see the patient has points. SOFA score stands sequential organ failure assessment score. It's you get points for how many organs are failed. So patient on the vent already, so you know there is 2 points, and depending on the gas exchange, it could be 3 if it's a poor gas exchange. Coagulation, liver points, cardiovascular points, central venous system points, and renal points. So you see the patient's SOFA score, meaning how the patient is progressing. There are different reports on the top. So first one is overview report. If you scroll down, you get the SOFA. There is also another benefit of the overview report. If the patient gets blood, you see the total volume of blood and how many packs RBCs and platelets and when it's given. For this particular disease, there's not a lot of blood transfusion happening, so it's not that useful. This is different ways of looking at labs. This is the lab report, followed by fever reports. I like that report because it gives you what the fever curve is, what the high, but also at the same time, what was the white count in graph and numbers, and what antibiotics received, not ordered, received. You can see this patient was on antibiotics till the 26th, and then the last couple of days they stopped the antibiotics. So you know what antibiotic the patient was received and when and what doses. And this is cumulative in 24 hours. So that's a useful report. The next is a 14-day micro, just to see the most recent update in the microbiology. These are the current meds that's ordered, whether it's around the clock or PRN. It's a quick summary for review. You can see here PRN and every 8 hours. And so you see the scheduled and the non-scheduled. This is order history. Just want to see what order has been placed so far and goes chronologically backwards. This order is not just medication, any orders. Discontinue folic acid and do certain things. Looking on the left side of the screen, I like the result review. I click on Common Labs. It's really formatted in a way that makes sense to us. It may not have the D-dimers. Actually, it should. It's there. It has the D-dimers. And you can see the trend of D-dimers was high and coming down. You can sort it from right to left to right. It's up to you. You can graph it as well. If you click on the word D-dimer and then right-click on the word graph, you can build the curve. This is the notes. When you click on notes, I would write ICU or critical care in this section, which is the smart text section. This is for the ICU attending. So when I type ICU ATT, and then it brings this template, and this is how it looks, formatted into 2 columns, brings a lot of links, including the plan of the day from the daily goals, which we're going to talk about in a second. And the rest is pretty blank other than links from the vitals and the ventilator settings and some I's and O's. And the rest we fill manually. This is a sign out. We're working on getting you your own sign out in your department. Matt Levin is working on that. And this is an example of the sign outs, brief history and updates on daily basis, and then what to do, what you need to follow up on. It's usually helpful when you're signing out something for the next day. Especially the beginning part, the header piece, it's useful. People not to lose track that this is large B-cell lymphoma or whatever it is. I think that was the last slide. I did not talk about the daily goals sheet, but you click on it, just go from the top to bottom. What are you planning on taking this patient or not? What's the plan of the day? And it's a free text. The benefit of that, when you type it, it comes to the nurses, it comes to the residents' notes, it comes to the attendings' notes, so people know what's the plan of the day and carry over. So the night shift, the nursing night shift, when they come and see, okay, we're planning on stopping sedation, wean a spontaneous breathing trial, we're going to increase the free water, so we need to follow up maybe the sodium, and the mobility goal is still nothing yet until we start mobilizing the patients. So that's a brief updates on the EPIC part and the workflow for you. Happy to take any questions, and I think we have a few minutes.
So there's a question about what happens when patients do die. There is a question as to whether we need an account in some other system, and how does the navigator work when a patient dies.
So there is a workflow. I didn't show it here, but there is a workflow for it's called the SHARS deceased patients. It's one of the tabs on the left. Let me share my screen. putting it here. You guys see my screen, Epic? Sorry. Dan, do you see my screen? The Epic screen?
So right now we see the PowerPoint.
Oh, that's interesting. Okay. You still see the PowerPoint. Okay. Let me minimize PowerPoint. Do you see the Epic screen?
I still just see the PowerPoint. Is it minimized? Because it looks like you're...
It is now minimized. Let me close it. Do you see? It's, okay, so hold on. I'll share my screen again.
Mm-hmm.
So tell me what you see.
Yep, now we see it.
Okay. I don't have it customized, but I don't use it as much. There is a rounding navigator you rarely use, and then click rounding. You can save that here under this. If you click on the star, it becomes one of your common shortcuts. And then when you go in the rounding navigator, you will see expected discharge. There is a discharge deceased process. I don't see it. A discharge. Let me see. Maybe it's a different one. Hold on 1 second. Discharge. Okay. There's another way you can just save the discharge. And then when you click on discharge, see this tab here, discharge deceased patient. So go to more, rarely used, and then hover under discharge, and then you click on the star, so it will be easier. And then it goes from top to bottom, but click on discharge deceased patients, and then go through the order set. Preliminary cause of death, some instructions, you go from top to bottom, and then you put an order. It's designed primarily to answer the most important question is, do you need autopsy or not? And then that form goes to the morgue if we need autopsy. If you don't do it very often, which I expect none of you have, I would rely on the primary team in doing it. If there is a primary team for the patients, I think that will work better. You need to have login with the eVitals. This is a New York State Department of Health registry, including death certificates. You need to register. You need to use your phone and face recognition. If you haven't done it, if you don't want to do it, I think the easiest would be asking the primary team who do that all the time, medicine teams as well. I think that would be the most efficient way. But you can write the discharge summary, you can write cause of death, you can write the death certificate, the beginning part of it to help them out.
Okay. I think that is the long and the short of it. We are going to try to make a tip sheet based on some of the slides here as far as the Epic flow sheet is concerned. So if you guys have specific things that you want to be on there, shoot me an email. Thank you so much, Dr. Marcus, for taking the time to show all this stuff to us. As you said, we're all in together. So, so thank you. Thank you very much.
Thank you. If any questions, guys, email me, or you can come and corner me in the CQ. I'm there. Thank you for the opportunity.
Thank you, everybody.
Take care.